Good afternoon, everyone. Thank you for joining Harvest Point today for this long-term care webinar. We're excited to share all that we have today. We've got a great guest speaker to share her expertise. And, as I was thinking about this webinar, long-term care can be a bit of a heavy subject. When we're thinking about end-of-life planning, thinking about our own mortality, where we might be when we pass, it's a bit of a challenging emotional conversation to have. It's not often an icebreaker question that you might ask somebody over coffee or something like that. In fact, I was thinking about a conversation that I had with my grandparents this past weekend. I was asking them about what their childhood was like growing up in the 50s and raising kids with all the different technological revolutions that happened since that time. They grew up calling the operator to get in touch with a friend. And by the time today, they can video conference with anyone in the world, anytime they want, with a mobile device that they can keep in their pocket. So a ton of change for them. And they recently retired and have been thinking about their life, playing kind of the what if game, different vocation, or had moved to this or that place. And as they were doing that reflective work, it made me think of a Latin phrase. It reminded me of it. It's memento mori. It's loosely translated as remember your death. A bit morbid, perhaps, but I think when we consider our lives, we realize we're not in control. Tomorrow is not promised to us. In light of eternity, our Lord gives us today, and that's all we're promised. In a way, it can be freeing to think about that. It allows us to be present. It almost forces us to consider the actions we're taking today. And as we think about that in the context of long-term care, we realize that planning for these things is act of love to those around us. So just wanted to frame that in that context of long-term care today.
I really appreciate the intro and opening there, Jacob, and some really important things to think about. But one of the things that we like to do from time to time, as you all know, and what we're doing today is providing you with a webinar. We try to make these webinars educational, and so that'll certainly be the case today. And so our agenda is pretty simple. I'm going to provide us here in a minute with a bit of an office update and a market update like I usually do. And then we'll get to our featured presenter after that. And then, of course, we'll have some time at the end for some Q&A. So if you have not already submitted your question, please do so. And we would love to hear from you on that. We'll have instructions here in just a second on how you can do that. But we'd love to answer those at the end of our presentation. Again, as many of you know, because I know we have on the call today a few different states represented, a number of clients and guests. And what we do at all of our events is we feature a charity partner. It's important to you, we know, to give back. We get to sit alongside you in meetings and really throughout the course of your lives and just see how important generosity is to you. So likewise, it's important to us, and those are the people that are affiliated here with Harvest Point. And so we're happy and pleased to partner with the Arthritis Foundation for today's event, and we'll be donating to them on behalf of all the attendees that we have here today. In fact, one of the members of our office, Tim Fitzgerald, is a member of that organization, helps lead the local chapter here in the Des Moines area. So I know that's near and dear to that organization is near and dear to him. I know many clients have suffered from arthritis and are currently suffering from it. So definitely an applicable organization, and feel free to go out to their website and learn more about them. As I mentioned, we will have an opportunity for questions. So email those to info@harvestpointwm.com. And we have been compiling those already. We'll continue to do so during the webinar today. And then at the end, as I mentioned, we'll have time for questions. As it pertains to the office, a couple of quick announcements. We do have a YouTube channel. That's something that's new for us. We've been kind of compiling videos there. So please feel free to look us up on YouTube and subscribe to our channel. We intend to continue to build that channel out. All of our webinar replays can be found there as well. So today we're capturing a replay of this particular webinar, and we will be able to provide that out. So in case you have family, friends that might want to learn about this topic, do feel free to share the replay with them. As I mentioned, generosity is so important to us because we know it's important to you as well. We have formed a charity partner committee. So one of the things that we're doing is if you happen to know of an organization that you might want to connect us with, we would love to learn more about them. We're always looking for, just like the Arthritis Foundation, always looking for charity partners for our events and try to build that out well in advance. So our committee is responsible for reviewing any applications in that regard and information that might be submitted. And then, of course, we select one for each of our events. So do please feel free to send us that information. If you go out to our website, under the Giving Back section. During each of our Monday meetings, we make a point to review our prayer requests, pray for you specifically by name, just because we believe in the power of prayer. So a few quick office updates in that regard. Another thing that we always do on these webinars, just as an introductory form of communication, would just be to give a little preview about who Harvest Point is. And really, we exist to faithfully guide and equip our clients to wisely steward the wealth that has been entrusted to them. We've been fortunate to be in business for quite some time now in one fashion or another, affiliated with one firm or another. We, as a firm, have 73 years of combined experience, and we're thankful for a 98% client retention ratio. We have great long-term clients over many decades, and very thankful for the fact that they have entrusted us to help with their financial planning. And really, as you can imagine, they have become friends. And we are family owned and operated. And really, kind of three words that would describe our firm would be personalized, comprehensive, and faith driven. We meet with you individually, face-to-face, or via Zoom like this, or telephone, in order to deliver our financial planning services, to come alongside you and help steward what you have been entrusted with. And that's kind of Harvest Point in a nutshell. Of course, the people that make up Harvest Point are critical. And really, in particular, as I just mentioned, kind of the phase that we're in life, each individual on the screen, to a person, was so kind, stepping up at the office while I was able to spend a couple weeks helping out at home. And so I'm really grateful for everyone that you see here on the screen. I won't go into too much detail about anyone in particular, but feel free to go out to our website and learn a little bit more about each of these individuals. They come to work every day with a great attitude. They roll up their sleeves. They're in problem-solving mode. And really, what impresses me probably more than anything else, maybe aside from their selflessness, would just be their advocacy. They really advocate for you as a client. Just come, again, whatever the problem might be, they're going to come and fight for you on that. They're going to solve the issue. They're going to make the telephone call. They're going to crunch the numbers. So really grateful for each of these individuals. And we're blessed to have these folks that make up the internal side of Harvest Point, just like we're blessed to have so many great clients like you. And on that note, one of the things that really helps us out is if you don't mind sharing what your experience has been in working with Harvest Point over the years, you're able to do that. And there's a QR code on the right side of the screen there. Just gives you a little a link that allows you to leave a Google review on our page. And like I said, that really helps prospective clients just have a little bit of a better idea of what it might be like to work with us and hear that directly from you. And then on the left side, if you do have someone who might be interested in receiving a second opinion, we're happy to provide that in a complimentary manner. And the starting point for that is to scan the QR code on the left. And that allows the prospective client to fill out a discovery form. And that's our first point of contact with them. And then we'll kind of take it from there and determine if we would be best suited to serve them. With that said, I did want to touch on what's happening in the markets right now. And really, if we think back on the month of April, probably one word rises above the rest, and that is volatility. We had some pretty substantial volatility, which in and of itself is not abnormal. However, the levels to which we had the big ups and downs throughout the month maybe is not all too typical. If you go back and look over the past 75 years, a decline of anywhere from 15 to 20% usually only happens in about 32% or less of the instances. So that's not too common. What is common is the market goes down almost every year at some point in time during the year. And you can kind of see that on the far left side. A 5% decline happens 91% of the years. However, we got down a little closer to that 20% range, didn't quite hit it on the S&P 500. And so that kind of sets it apart as a little bit of an atypical year from a volatility standpoint. So it's kind of good to have that perspective overall. Also, kind of sticking with maybe the bad news, whenever there is a downturn of about 15%, or in the case of last month, we got down a little bit more than that. Typically, that does not mean that we end the year with a positive return. However, there are some notable exceptions that you'll see on the screen. A lot of the analysts and fund managers that we follow tend to believe that we might be a bit more aligned with those exception cases here in 2025, and I'll speak to that in just a minute. But nevertheless, when the market does what it has done just last month, then typically it means we end the year in negative territory. However, because we did not get down into bear market territory, whenever we have a correction in that 15 to 20% range, interestingly, if you look out 1 month, 3 months, 6 months, and 12 months, in the instances charted here on the screen, and there are 7 of them, this would be the 8th if we follow suit, there actually is not an example of a negative return at any point in time looking into the future based on what we've experienced so far. So, again, we don't know if the correction is over. We don't know if we'll go back down into a bear market territory, but at least based upon what we do know, there's some positive sentiment on a forward-looking basis over the next 6 to 12 months. And I won't bore you with, I could probably put up about 5 more slides that supports this case, but we figured we'd stick with this one and at least be able to rely on that for what we're looking forward to here in the future. So if we do go into that bear market case, really it kind of strengthens that forward-looking analysis, certainly over the next 1, 3, and 5 years. And we won't go through each one of these instances, but whenever we have had a bear market, and we kind of have listed the event thanks to our partners at T. Rowe Price on the left side there, and you'll remember many of those, of course. A lot of those lasted for a short period of time. Others lasted for 1.5 years in the case of the global financial crisis. But really, again, if you look out 1 year, 3 years, 5 years, some pretty compelling data when it comes to the positive returns over that forward-looking period of time. So that's kind of what we have our eye on in terms of what has happened so far. And really, if you look at April, it's kind of interesting. I was just looking at a chart this morning on a client's account. If you look at it on a line graph, April looks like a Nike swoosh. So we went down pretty sharply, but actually, if you can believe it, this is the last day of April. Unless something substantial happens today, which it might, there's always volatility, and I think there was this morning. But all that being said, we might even finish April with a positive return in certain or some cases for clients' portfolios, depending on how much risk you're taking. So we really did have a bit more of a sharp recovery in the S&P 500 after that sharper decline, which is a good, as I mentioned, that is a good sign for the forward-looking sentiment. The final 2 charts I wanted to share just have to do with kind of an example. So we have 2 investors. One is what we would call a steady investor who is invested for the long term, the ups and the downs. That would describe our clients. And then we have investor number 2 would be the anxious investor. And they're jumping in and out of the market constantly, trying to time when it's going to go down, when it's going to go up, which no one can do. And if they tell you they can, they're likely lying to you. It's very difficult to do that. But what's interesting is if you look at this scenario over the past 20 years, and Lauren, you can go to the next slide because this kind of summarizes it. Investor 1 took advantage of the lower stock prices through their ongoing contributions and remained in the market, and they were rewarded as the market continued to recover. Investor number two earned less than a quarter of what the steady investor did because they tried to jump in and out of the market. So, as the quote in the bottom right indicates, in times of stress, we feel like we need to do something, even when the best course of action might actually be to stick with a plan that we already have. And certainly that's the case for our clients. Lest you think that we're not doing something, we are. Not only are we actively rebalancing, we have prepared for these downturns. We have taken them into consideration as together we have evaluated the risk tolerance within your accounts. And that's different, obviously, per account. But nevertheless, times of volatility can be stressful. They can bring questions to mind. That's what we're here for. Don't ever hesitate to give us a call. We love talking through those instances with you. We're here for you. We're on your team, and we work for you, and we're very privileged to be able to do that. So with that said, I would like to introduce our guest speaker, and we'll get to the main topic of today's webinar, which is long-term care. And of course, as you know, because you saw when you signed up, Eileen Dunn of Associates of Clifton Park is our guest speaker. And Eileen is a national speaker, author, care manager, and corporate gerontologist, and she is with Associates of Clifton Park. They're a national leader in the long-term care insurance space and have been since 1995. They've helped actually write over 100,000 long-term care insurance policies. I'm sure the number is probably higher than that, increasing every day. And they do so across all 50 states. So Eileen brings decades worth of experience. As I mentioned, we're very privileged to have her and get her perspective on long-term care. And I think you'll be very interested in her presentation. So with that, I will turn it over to you, Eileen, and thank you so much for joining us.
Okay, well, thank you for having me, and good afternoon, everybody. I always like to call this the conversation every family should have, because I do think that it's very, very important. But first of all, I'm going to start out by saying that this is really strictly about education. Our goal here is not to give you, financial or legal or medical advice. It's strictly to help you understand what long-term care is. So I'm a little bit of an anomaly when it comes to this world, working with the financial advisors and the insurance folks, because I'm actually a medical social worker, and my master's is in health services administration. And the way I got so passionate about long-term care planning is that I had been a hospital discharge planner for 8 years. And the hospital discharge planner is the one that organizes all the post-hospital care, nursing home placement, all of that. And I saw people lose everything to long-term care, but I also saw people in their 50s lose everything, even to a rehabable event. And I've literally grown up with this because my grandmother had one of those old-fashioned nursing homes in her house. So we always had about 8 to 10 people. She never called them patients, but people in the house. So I can say I have literally been around this for my entire life. And when I left the hospital, I took a job as special assistant to the director of the New York State Medicaid program. I live up in the Adirondacks in upstate New York. And when I took that job, I started and I heard about this thing called long-term care insurance, because New York was part of what they call a partnership program, which we'll talk about a little bit later. But here I'd been working in a hospital every day, and I'd never heard of this thing called long-term care insurance. I was used to dealing with Medicare, Medicaid, Blue Cross. So my first response as a patient advocate was, okay, yeah, right. What's the catch? Something sounds too good to be true. Chances are it is. So for the 3 years that I was there, I went through long-term care insurance with a fine-tooth comb, fully expecting to expose it for the farce that it was. But then I realized, this could really do what it's supposed to do. The problem is that we had people that were trying to talk about it, but really didn't understand the whole picture. Like, for example, you don't go to your cardiologist to have brain surgery, even though they're both licensed physicians, right? There's areas of specialty, and I believe very strongly that long-term care is one of them. But after 3 years with the state, I missed direct care, so I started a private practice as a geriatric care manager. Now, if you haven't heard that term, There is a National Association of Professional Care Managers, but the best way that I can describe that is it's like being a professional daughter. I get the calls from the stressed out kids. They don't know what services are available, how to access them. Very often they don't live in the same area as mom or dad. Long distance caregiving is kind of a big thing now. So I'm the one that goes out, does the home care assessment, tries to put the care in place. I have some clients that need 24-hour-a-day care. I have some families that just need a roadmap. So like I said, it's kind of like being a professional daughter. But when I started that business, the director of the partnership said, Eileen, you really should incorporate long-term care insurance into your business because there's really not a lot of healthcare people doing it. And I thought, well, I'm not sure if I wanted to do sales, but I felt very strongly people needed to be educated. So I started attending some seminars. And what I found is that people were getting flat out wrong information. And it really wasn't intentional. They just didn't know what they didn't know. And that's some of the background and what goes on behind the scenes in healthcare. So that's part of what we want to kind of help educate you on today. So I currently work full-time with associates at Clifton Park, and I'm on the road, working with financial advisors and their clients. But I also still have my private care management practice, which is Trinity Elder Care, that I do in addition to working with that. So having said that, now we'll move on. And now we get to the real fun. I'll often ask, do you have a long-term care plan? And a lot of times people say, well, no, I don't. But the reality is everybody does have a long-term care plan. My goal is that you sit with your advisor and look at what your options are. Then you're going to make an educated decision. And we're hoping what we talk about today will help you make that educated decision because we don't want you to stay on the default plan. So the big question now is, what exactly do we mean by long-term care? When we say long-term care, most people think nursing home, end of life, all of that. So I'm going to ask you to erase all of that. What it means is when someone needs what we call standby assistance with these things called activities of daily living. And we refer to them as ADLs. And there are 6 of them. It's bathing, dressing, eating, continence, transferring, and toileting. And I promise toileting is not as offensive as it sounds. Very often that's just assistance getting to and from or with clothing adjustment. Now, standby assistance means someone within arm's reach for safety, fall precaution, verbal cueing, that kind of thing. But there's another level of assistance that I think is very important to talk about, and it's called instrumental activities of daily living. We often refer to those as the homemaker skills. Those are things like meal preparation, laundry, light housekeeping, shopping, that kind of thing. So this right here is really what we mean when we say somebody needs long-term care. It's assistance with the ADLs or the IADLs. Now, when you need that assistance, one way or the other, it has to be paid for, right? People don't work for free. So the big question is, what resources are available to pay for the care? Well, you have your primary health insurance if you're under age 65. Once you turn 65, that would become Medicare. You have Medicaid, you could pay out of your pocket, or you have the private insurance, right? That's really the only way that care is going to be paid for. Now, when it comes to your primary health insurance and Medicare, just a couple of points on that. Medicare was designed to replace your primary health insurance when you turn 65. In fact, when they created Medicare back in 1965, the primary payer was Blue Cross Blue Shield. And Blue Cross was for the hospitalization, Blue Shield was for the doctors and the outpatient. So they said, when we create this program, if we base it on something people are already familiar with, it'll be easier for them to understand. That's why we have Medicare Part A, that's for the hospitalization, and Part B, that's for the doctors and the outpatient. It was designed to mirror health insurance. Now, the biggest thing that I want you to understand about health insurance is that is primarily about treatments and diagnostics. So if you go to the doctor, fine, your health insurance will cover. The doctor says, okay, I need to run some tests. Okay, fine, your health insurance is going to cover. But now maybe you have a diagnosis of Parkinson's or cancer. This primary health insurance doesn't cover the care that you need because of that diagnosis. So this is primarily, again, Medicare and health insurance. Just think treatments and diagnostics. Okay, now with your primary health insurance and Medicare, there is a certain amount of limited home care that you can get. But one note to make on that is technically home care doesn't even have to be covered under Medicare. It was never in the original legislation. They added it because they thought they could get people out of the hospital a little bit sooner. But in order to qualify, you have to have had a 3-day hospital stay, have to have been in the hospital for 3 days. And then when you go home, there's 4 very specific criteria that you have to meet. And the first one is you must require a skilled service. Anytime you see the word skilled care or skilled service, what it means is anything that requires a licensed professional, like a nurse or a physical therapist or an occupational therapist. The second one is you must be considered homebound. That means physically unable to leave your home without substantial assistance. And a wheelchair is not necessarily considered substantial assistance. So it's not just that it's, February in Iowa and you don't want to leave your home, but physically unable to. You also must require hands-on care. Now, just a minute ago, we talked about standby assistance that meant someone within arm's reach. This means hands-on care. You must require physical assistance with the task. And the last one is your care must be considered restorative. You need to be showing signs of improvement. And you have to meet all 4 of those criteria. So how would that actually work? Let's say that someone is in the hospital and they had some surgery and they're getting ready to go home. And the discharge planner says, Mrs. Smith, I don't like the looks of that wound. So I'm going to make a referral to the public health nurse. So you get home and the public health nurse comes out and says, yep, I need to change the dressing on that wound twice a week. Well, that's a skilled service because that is something that the nurse has to do. Now the nurse says, well, I see you meet this other criteria. You're homebound, you need hands-on care, and you're also considered restorative. So I'm going to create this plan of care, and we'll have a home health aide come out a few days a week, and here's what she's going to help you with. So everything's going along fine. You have a home health aide a few days a week. The nurse is changing the dressing, but 5 or 6 weeks goes by. What's happening with the wound? Hopefully, it's healing. So now the nurse comes out and she says, well, Mrs. Smith, skin integrity is intact, risk of infection is gone, you're discharged from nursing services. What's going to happen to the home health aide services? Sometimes people think, well, it's just going to go away. It's not going to go away. The agency that's providing the service will just say, Mrs. Smith, you're no longer eligible to have this covered under your primary health insurance. So how would you like to pay for it? So again, the most difficult part about getting the home care at home is the skilled part, because Medicare is always attached to a skilled service. I had a home care client a few years ago. He had a Foley catheter, a colostomy. He had to be turned and positioned every 2 hours. And when we did get him up, it was with a Hoyer lift. Now, would you consider that to be skilled care? Most people think, well, I would think so, but it wasn't. Once a month, when the nurse came out to change the Foley catheter, that was a skilled service. All the other daily care, burping bags, changing wafers is not considered skilled care. So that's the tougher criteria to meet. So the next thing we had was Medicaid. And right now we're talking about home and community-based care because honestly, that's where most people do get their care. That's where people want to get their care. But they can't rely on Medicaid for that. Home and community-based Medicaid is very different. And technically, Medicaid, you'll hear it referred to as an entitlement, but it really isn't. All the entitlement programs like Medicare, Social Security, that's Title 18 federal funds. Medicaid is Title 19 federal funds, and it's intended for people without means, and you have to meet the federal poverty guidelines. And for this year in Iowa, just for home and community-based Medicaid, a single individual cannot have more than $967 per month of income or more than $2,000 in assets. And for a husband and a wife, it's almost $1,300 a month of income and about $4,000 in assets. And honestly, this was one of the reasons why I really, really delved into the long-term care planning. I had many, many patients in the nursing home or in the hospital that I had to place in the nursing home that could have maintained at home. The problem is when you're at home, you still have to buy the food, pay the lights, you have all the expenses for being at home. And now when you have to start paying somebody to come in, a few hours a day and to help with things around the house, usually that's coming from people's savings. And what would happen when the savings is gone? Well, again, people don't work for free. Their condition would deteriorate and they wind up back in the hospital. We can't legally discharge someone to an unsafe environment. And we know it's an unsafe environment if they need a certain amount of care. The problem is their savings is gone, but their Social Security and pension is well over that $967 limit. So the problem is they did not qualify for home and community-based Medicaid. And then we've had some people that said, well, we'll put all our money into an irrevocable trust. That doesn't protect you against the cost of home care because you're always going to be bound by the income guidelines. So even if you give all your assets away and you say, well, I don't have any assets, if you want to get care at home and your income is more than that, you're not going to qualify. So that's with Medicare or Medicaid. So, but consider this. I have been doing nursing home placement for almost 40 years now. And honestly, there's only 3 reasons that I have to place somebody in a nursing home. And 9 times out of 10, it is because they've run out of money. I can make anything happen at home, but it has to be paid for. And the second reason is caregiver stress. And this is why I say this is the conversation that every family should have. Caregiver stress is huge. And I think that sometimes people kind of underestimate the stress of being a primary caregiver. And the last reason is that their needs did increase to that level where they required that level of assistance. But it's almost always after the home care options have been exhausted. Okay, now, if someone did have to go to the nursing home, it's a little bit different. Medicare is going to cover day 1 through day 20, the full 100%. But like I said, Medicare is always attached to a skilled service. So if you know of anybody that's ever been in a nursing home, or if you've ever visited a nursing home, what kind of care do people get in a nursing home that you would be considered skilled care? I'll let you think about that for a minute. You also have to have had a 3-day hospital qualifying stay. But the average number of days that Medicare actually pays is only 18. And the reason is because of that skilled service. The biggest thing that keeps people in the nursing home at a skilled level of care is going to be physical therapy. But just like with the wound care, after a few weeks of physical therapy, what happens? What happens is you plateau. You're no longer showing signs of improvement. I remember that was that other term I said, restorative. You need to be showing signs of improvement. So once that improvement stops, you're stepped down. But if you do remain at, that skilled level of care, from day 21 through day 100, Medicare will cover all but the Medicare deductible, which is about $257 this year. However, after day 100, Medicare doesn't cover doesn't matter what level of care you are, Medicare doesn't cover. It was never intended to cover long-term care. Again, it's health insurance, so it's basically treatments and diagnostics. And I think it's for a lot of these reasons that people are turning to funding options. And I know a lot of times people say, well, this is big issue now because we are living so much longer. And you're absolutely right. Like I said earlier, I grew up in a nursing home, and 50 years ago, you had good genes. You live to age 90 now, and you're on a list of medications for things 50 years ago you may have already died from. But it's all of these reasons together is why people are turning to the private funding options. The reason from the healthcare perspective, because again, I live on the other side of the fence of this, and I will tell you that over the last, especially the last 7 years, more and more of my home care clients do have the long-term care insurance. So I go through the claims process quite a bit. But what I like best about it is how you actually access the services. And that is that your physician certifies that you need standby assistance with 2 of those activities of daily living. And just a reminder, that was bathing, dressing, eating, continence, transferring, and toileting. Once you meet that 2 ADL trigger, it also covers assistance with those homemaker services that we talked about, like the meal planning and the shopping. And I think that that's really, really important. Now, when it comes to those ADLs, bathing and dressing are usually the first 2 ADLs that people need assistance with. And they're the easiest to manage in a home care situation because they can be scheduled. And I know a lot of times people think, well, if anything happens to me, my spouse will help and vice versa. And that sounds great. But when I go out and do a home care assessment, I don't want the spouses helping with bathing and dressing. There's too much twisting, there's too much turning, there's too much risk for injury. The last thing we need when we have one spouse needing care is to have something happen, we have one spouse needing care. We don't want anything happening to the well spouse. And I want to talk and dig a little bit deeper on this standby versus hands-on, because I think that that is important. When we go to the bathing, remember, under your primary health insurance, you must require physical assistance with the task. So that's just that physical assistance with the bathing process. But with the standby assistance, we help the person into the shower, we close the curtain, they hand their robe out, they wash themselves, they'll turn the water off, we hand the robe in, and we help them out. Well, what happened there? 2 huge things. First of all, the person's privacy and dignity is maintained, but also they're able to access services when they're still at a higher level of functioning. If you have to wait till you need hands-on care, you've deteriorated, right? What's one of the biggest risks for people at home? Falls. And where do most falls happen? In the bathroom. Okay. And the other thing with dressing, it doesn't mean somebody needs to completely dress you. Very often people just need assistance because of balance issues, other type issues, range of motion issues. They might need help just getting pants on just up over their knees, and then they're okay to stand up. So that difference between standby and hands-on, I think, is really important. And again, I look at this as preventive medicine. I have some people that have thought, well, this is to have somebody to come in and do things for you when you can't do it for yourself anymore. I look at it as the opposite. It's there to prevent something from happening, preventing falls, preventing malnutrition. A lot of times seniors, their nutrition goes downhill. That allows you to stay home and living more independently. And when it comes to the caregiver stress, remember that primary caregiver has to continue doing all their tasks and household responsibilities. They have to pick up what the care recipient is no longer able to do. And on top of that, they're the primary caregiver, which means, getting all the medications, the doctor's appointments, all of those kinds of things. Now, if I tell you that it's very likely you're going to need 6 hours a day of care, what do you think your physical condition is? Most people think if I need 6 hours a day of care, I must be in rough shape. But honestly, by far, this is the care that I put in place with my home care clients, even if there is a well spouse available. I have a husband and wife right now, and it's the husband that requires the assistance. We have a gal that goes in from about 8 to 11 in the morning. The wife has already gotten the breakfast, so when she gets there, she'll throw in a load of laundry, Another task I'd prefer the seniors not do because of the lifting and twisting, carrying that basket. So she'll throw in the laundry. She helps him with his bathing and dressing, the morning grooming, makes sure the morning meds are done and gets him through the lunch hour and cleans up after lunch. There's 3 hours right there. It's also 3 hours that gives the primary caregiver a break. Sometimes she'll just go and read, or she'll run errands. She walks the dog, but it gives her a break. And then they're fine during the afternoon. We have a gal that comes in from the evening for 3 hours. She'll put away the laundry from the morning, gets him through the dinner hour, helps him back into his night clothes, does all the make sure the evening meds are done, and cleans up after dinner. Okay, but that's 6 hours a day of care right there. But it's also 6 hours at $25 an hour. And actually that cost is getting up closer to 30 now, but I can still get some for 25 an hour. You're looking at about 50,000 a year, and that is just for basic care. Okay, but what I also wanted you to see is, you see how those homemaker services and the ADLs kind of come into play. But it's 6 hours that makes the caregiver and the care recipient's life easier. And it really does protect the caregiver. The way I look at it, it doesn't replace what families do for each other. It just helps them do it better, longer, and safer. So that's kind of the ins and outs of long-term care from, there's a little bit more behind the scenes, but I don't want to dig too deep. But I will say most people don't go to the nursing home, especially now that we have these great long-term, the assisted living facilities. I think that they're great. And we also have what they call enhanced assisted living. So they're able to provide even an extended level of care. But the biggest thing is that you want to be able to choose where you get your care and who gives it to you. So this is just going to be very high level to finish up on how you would design a plan. This is where your advisor and our team can really come in helpful, because there is no cookie cutter for this. You choose, if I needed care, how much do I want this insurance to cover? And you can choose any amount you want. Most of the time we'd say, okay, how much can you reasonably afford to pay out of your pocket without affecting the quality of life of the well spouse or rapidly depleting the assets? Because I don't think that people need to overinsure. So in this example, if we're saying it's $5,000 a month and I want this to cover for 48 months, that's a pool of money of $240,000. So what we're talking about here is just the pool of money. What I want you to remember about that, though, is that care comes about incrementally with this pool of money concept. So if you are getting care at home and you're only pulling out $3,000 a month, well, then that 48 months is going to last longer. So it's based on a pool of money. That 48 months is really just a way for us to measure how much to put in that pool of money. But it also, I've had several clients, well, about 4 clients, that have used their long-term care insurance and have come off claim. So it's not necessarily just end of life. One client was in her mid-50s and had some real bad complications when she broke her wrist and her pelvis. And then I had a couple of teachers where the husband was going through cancer treatments and he was on claim for about 1.5 years. So it's not necessarily just end of life. It's that, but the pool of money concept is this. It's, if you don't use it, you don't, lose it. You're going to, that 5,000, that extra money will stay in there. Because again, the care comes about incrementally. Now, Iowa is part of the partnership program. And what that means is that if you have a long-term care policy that qualifies for the partnership and you exhaust the benefits of that policy, you can protect a certain amount of assets, however much that policy paid out. Now, what would currently happen is if somebody had a couple, say, with $400,000 and one spouse has to go to the nursing home, there's something called spousal impoverishment where they say, okay, well, the nursing home needs this 9 or 10,000 a month. Where am I going to get that? I still got to keep the house going. They go to apply for Medicaid. Medicaid's going to look back 5 years and they want to look at all of your assets, but they don't want the community spouse to be impoverished. So that they say the community spouse can protect half of the assets to a maximum of that $157,900. So where we see without partnership, they go in, they apply for Medicaid. Medicaid says, okay, well, you have your 157 of a protected resource, but that leaves $242,000. They call that an available resource. That is available to help pay for your care. Now, again, like I said earlier, Medicaid is technically not an entitlement program. Okay, you have to meet certain financial guidelines. And they have a fiduciary responsibility to you because you are the taxpayer and you're the one paying for it. So they say, if you have the ability to pay, we're going to be the payer of last resort. Now, if someone had a long-term care insurance policy that qualifies for the partnership, that same couple with that $240,000, they go to apply, they say, okay, $157,000 of available resources is protected for the well spouse. Now that $242,000, when you had that pool of money of $240,000, that's now protected because the Medicaid will say, you know what, you did your part. You tried to provide for your care and you beat the odds. So for every dollar that policy paid out, you can protect a dollar of available resources. But that is just one. And I only wanted to talk about that because of the partnership. All of our options, we also have life insurance policies that have a long-term care rider. We also have asset-based. This is where your advisor is going to come in very, very helpful, helping you determine, if or which one of these is going to be the best solution for you. The long-term care life insurance with a long-term care rider does, of course, have a death benefit. But if you go on claim, the first thing you're going to be spending down is the death benefit. Then you would go into the long-term care rider. And of course, we have asset-based where you could transfer assets into a life insurance-based product. But again, my goal was to help you understand long-term care really from the healthcare perspective and know that there are some really great options out there. I believe very strongly, especially since I've seen more and more. One of the first questions I ask when I get, usually it's the adult kids that are calling me about mom or dad. One of the first questions I will ask them is, do they have long-term care insurance? Because for me, it's just one more tool I have in my box to know what I can do, where I can do it, and for how long I can do it for. So with that, I think I will pass it back.
Yes, Eileen, thank you so much. Very, very informative. And we do have some time left for questions. I know we do have those coming in. So Jacob will jump on here in just a second and walk us through those. One thing I wanted to point out, though, just we have a number of clients on the call who actually do have long-term care insurance presently. And you might be aware, or perhaps not, that depending on your age, those long-term care premiums could potentially be deductible on your tax return. So we won't spend too much time on this. We will include it in the follow-up resources that we send out afterwards, but be sure to let your tax person know, if you haven't already, that you do have long-term care insurance.
Tim, can I jump in on one thing with that? I think that's great. Another thing is that if somebody is a business owner, the business, can buy it. That's another thing that we can look into. But also, I've had some people that have thought, well, I've got a pretty good, net worth here, and if something happened and I needed care, I could pay for that myself. I could probably pay for it out of my pocket. The problem with that is that if you can afford to pay it out of your pocket, chances are you could afford the premium. And I would strongly advise that, because when you have to start pulling that money out of your pocket to pay for care, at some point there's probably going to be a taxable event there. And guess what? It doesn't matter what the market is doing, whether it's up or down. When it needs to come out, it needs to come out. when you get the benefits from the long-term care insurance, that's non-taxable income.
Yep, very helpful additions. That's exactly right. And we've sadly sat across the table from many children of clients who have had to deal with long-term care stays, of course, and some have lasted quite a long time. So the difference that the policies can make is substantial. It really is. So great additional information. And then finally, on the screen, you'll see the Family Caregiver Alliance. There's a website there you can go out to for more resources, information. Again, we'll include that in the final email that we send out. So with that, I'll turn it back over to you, Jacob, and you can kind of lead us through the question and answer session.
Absolutely. We do have a couple questions here. We'll start with Eileen. The first question: my daughter lives in the same town as me and has assured me that she will be caring for me in the future should I need assistance. Do I really need long-term care insurance?
Yes, for a couple of reasons. Number one, I've had many instances where we thought that was going to happen. In fact, there was a family where there were 5 kids, all lived locally. 2 of the adult kids died before the mom and dad. I've also had an 85-year-old client who is the primary caregiver for her 65-year-old daughter. You just don't know what's going to happen, and that sounds good, but that daughter also might need some support herself. So with a case like that, even if they have a policy that's going to cover like $100 a day or $150 a day, and they could get some asset protection, it's very good to have that in place, because the stress of being a primary caregiver is it can be a little bit overwhelming. I'm working with a daughter right now, and she's an only child, but we have to have 24-hour day care in there for the mom. That just came about quickly over the last couple of months. So yeah, I would advise that.
Great. Yeah, thank you for that. The next question is directed for Tim and market related. I have some funds to invest. Should I do so now or wait until the market calms down a bit?
Sure. We receive that question often. In fact, over the past couple months, we've been walking through that with a number of different clients, many of whom have added money to their accounts during this downturn. It'd be as if you and I went out to Target and there was a 10 or 15% sale, at least at one point last month, that was the case. Earlier in our presentation, we spent some time talking about the month of April quite a bit. If you pull back and look just over the course of the whole 2025 year, we are actually still negative in most portfolios. Certainly in most equity markets, we're still negative year to date. The international realm would maybe be the exception there, and bonds have held pretty strong. So all that to say, there still is, I think, a really good buying opportunity available presently. Of course, as with any investing decision that involves the risk of loss of principal, it varies depending on your risk tolerance and, of course, your time horizon. So please reach out to us and we'll have more of a detailed conversation about your individual situation, and happy to help evaluate that.
Great. Maybe have time for 1 or 2 more. This one's for Eileen. What's the most common mistake that people make related to long-term care?
Do you mean the insurance wise or just long-term care planning in general?
Maybe planning in general. It's probably more so that.
I think making sure that your family knows exactly what you want and being honest with those conversations. And it's also a matter of being honest with what they are capable of doing. And the daughter that, wants to be there for the mom, I think that's great. But we have to say, is that realistic? And what's the plan B? So that might be plan A, but you also might need a plan B. But most importantly is the education and communicating exactly what they want and what they don't want.
And I would just jump into on that and say, I couldn't agree more with Eileen. A lot of times, and I'm sure Eileen has heard even more of these than we have, but a lot of times we'll hear from clients, my plan is the long walk off the short cliff, or the, float me across the river, or I'm going to take a walk in the woods. And, there's some lightheartedness and humor to that, of course. But as Eileen would probably tell you, that is not ever how it ends up happening. And unfortunately, it ends up being a topic that doesn't get discussed or addressed, and then something happens.
Right, right. And sometimes I'll joke back with them when I hear that. And I say, the problem is you're not going to know when it's time, you know? You know? So, well, when the time comes, I'm just going to do that. And, often I hear people say, well, what if I pay this long-term care premium and I died and never needed it? And my response to that is always, and again, this is my field. I live on this side of the fence, so I don't want to bum anybody out. But the reality is there's only three ways we're going to die. It's either a sudden event, the aging process, or a disease process. And two out of those three ways are going to require some kind of care. So if you died and never needed it, it's because you died suddenly and you're never going to know, number one. And number two, would the real mistake be dying and not needing it, or living and wishing you had it? That's the hard thing. In fact, I have a lady that I had to go and do a long-term care. We were getting her on claim for her long-term care insurance a couple of weeks ago. She's paying over $6,000 a year for her insurance. And her son said to me that last year when she went to pay her premium, she said to him, I think I'm going to stop this. Why should I pay for something I'm never going to need? Well, now she's getting over $6,000 a month in benefit because something has happened. So he was very glad he held on to it.
Well, that's all the time we have for questions today, but thank you all for attending today's long-term care webinar. We hope you had a few takeaways, and maybe the biggest one is just to have that conversation with your family now sooner than later. So thank you all again, and have a wonderful rest of your day. And please do take time to fill out the survey that will come out to you via Zoom after the webinar.